Common induction agents are usually thiopentone, is cheap and liked by many people. But propofol is commonly used by us, high lipid solubility, high clearance, rapid distribution. Induction dose is based on total body weight. Infusion can be given also. Etomidate has theoretical advantage over the hemodynamic instability. That is done with lean body weight and other opioids to block the surgical stress and intubation reflexes. Fentanyl is commonly used, but nowadays we have remifentanil. Remifentanil is rapidly metabolized by tissue and plasma esterases. It has to give in ideal body weight. Remi can cause bradycardia and hypertension and muscle rigidity also. It can be used in TIVA as opioid component of TIVA. Inhalational agents, they are highly lipid soluble, so recovery time is rapid for both SABO and desflurane. SABO is rapidly absorbed and eliminated. Also, desflurane least lipophilicity and solubility limitation of distribution to fatty recommended for obese patients. So quicker. Neuromuscular blockers, Succinylcholine, good old neuromuscular blockers, short-acting, rapid onset, etc. Acetylcholine stress level, dose is on the dose based on total body weight. Vicurinium eliminated mainly by the liver. Duration may be prolonged if dose is based on total body weight, so it's better to go for ideal body weight. Rocuronium also weakly lipophilic and based on ideal body weight. Reversal has to be a complete reversal dose based on total body weight. Neostigmine is commonly used when tough ratio is 0.9. For there is delayed antagonism in obese patient, time to make TOF of 0.9 is fourfold than normal weight patient for vicurinium. So it may take time for reversal of the neuromuscular blocking. Deep block should not be reversed with neostigmine, and deep block should not be actually created for obese patient. Total dose should not exceed 5 milligram. Neuroaxial blocks, they affect respiratory drives minimally, so they're safe and appropriate for obese patient. But local anesthetics usually advocated without opioids, high block with the same dose of drugs given incrementally, so low dose sequential spinal epidural is better. Ultrasound to locate spinal anatomy. Another blocks or ultrasound blocks is safe with high success rate. They are very beneficial to obese patient. Obesity is an independent risk factor for peripheral catheter, but not neuroaxial catheter related to infection. So local anesthetic can be used for local infiltration or interfacial plane block and peripheral nerve blocks. About the plane blocks, that blockbusters in our department are using TAP, quadratus lumborum, serratus, and erector spinae. Erector spinae is a block that has somatic as well as visceral analgesia, so it's better than TAP. Some centers are using liposomal bupivacaines who are longer acting. Peripheral nerve blocks, femoral can delay ambulation, which is not good for obese patients. The brachial plexus block for upper extremity is very good, but for foot and ankle, we can give popliteal sciatic block. Regarding long surgeries, midline incisions, thoracic epidural is recommended. But if the incision is too long, it has to be supplemented with transabdominal plane block for subumbilical portion of the incision. Post-op pain should be multimodal opioid sparing. non-opioids such as acetaminophen and NSAIDs, regional anesthesia techniques, own infiltration, neuraxial or peripheral block. Regarding own infiltration, it has to be in detail, the subcutaneous tissue, near peritoneum, also musculofacial. It's not only the skin of the ports for laparoscopic surgery. Adjunct medications are for post-operative pain. Sometimes lidocaine infusion is given, systemic lidocaine. Low dose, very low dose ketamine, GABA, pre-GABA can be given, and alpha-2 agonist like clonidine can be given pre-op or post-op. Magnesium sulfate is given, and also dexamethasone. Other than pain management, post-anesthesia care management is that you have to continuously monitor pulse oximetry till the patient can maintain SpO2 unstimulated. If the patient is not able to maintain saturation despite supplementation, sustained decrease in the level of consciousness, then ABG has to be done. Oral, nasal, or combination of airway may be used. CPAP, BiPAP, or now modern ventilators have NIV mode also. They can be used to avoid reintubation, because reintubation is the most horrible thing that you can think of in post-anesthesia care unit. Reintubation, ultimately, if it is necessary, you have to do for refractory patient. For assessing spontaneously breathing patients' volume, we do not have impedance-based respiratory volume monitoring devices, but these are recommended. Adequate oxygenation, you can set by giving nasal cannula or oxygen mask with reservoir bag, so the saturation is maintained sustainably with more than 90. Patient should be sitting to 60 degree or semi-sitting or in lateral position but head up. And incentive spirometry, that we will be introducing preoperatively at home. And after 15 minutes in the recovery, we will do every 10 to 15 minutes for 2 hours. This has improved saturation. And to compare with the pre-surgery and post-surgery, we can do spirometric lung function test in PASU and also 24-hour post-operatively. So immediate, within hours, chest physiotherapists are called in and nebulization is done with bronchodilators or even normal saline to smoothen out secretions there. CPAP and IV, if not responsive to inspiratory spirometry, room air saturation should be to pre-op baseline saturation. Without supplementation, room air saturation should be there, so that when you are satisfied, that patient can go for ward or less intensive care places. So some more slides about our goal is to give the patient an enhanced recovery. So enhanced recovery, the main thing is that we have to identify, optimize the comorbid conditions, do prehabilitation and patient and family education and discharge planning, and avoidance of prolonged preoperative fasting, pain management plan, and for selective cases, DVT prophylaxis. Goal of surgical approach should be minimally invasive as much as possible. Antibiotic prophylaxis usually given 30 to 60 minutes before incision, but usually we are doing after induction. Use of short-acting anesthetic agents during induction and maintenance, avoidance of fluid overload, lung perfusion, mechanical ventilation, hypothermia, and pneumothermia, and euglycemia. Multimodal, intraoperative multimodal anti-emetic prophylaxis like dexamethasone and ondansetron at the beginning and ending. And if the patient has history of post-operative nausea, and vomiting or high-risk case of post-operative nausea vomiting like ENT surgeries. Haloperidol is a good option, or we can totally avoid GA or nitrous oxide and go for a TIVA process. Procedure-specific opioid sparing pain prophylaxis, local region anesthetics, acetaminophen, ketorolac. But for some long-acting IV opioids like morphine sulfate can be necessary before extubation. Again, rescue therapy for if in the postoperative there is PONV, we can give promethazine and another dose of 5-HT antagonist, but it has to be after at least 4 hours after if there is backthrow pain, we can give tramadol also. Oral feeding to be started as soon as possible, and early postoperative mobilization and physical therapy within hours. DVT prophylaxis, heparin 5,000 unit can be given 60 minutes before, plus bilateral sequential compression devices prior to induction of anesthesia. Some centers are giving oral acetaminophen paracetamol and also celecoxib B. Better to avoid benzodiazepines, but if some patients are difficult to separate from, we can give just before transfer 1 to 2 milligram midazolam. That is a study over 70 years of age patients, lorazepam study, 1,000 cases, but there was modestly prolonged time to tracheal extubation, delayed recovery, so lorazepam is no more advocated. Glycopyrrole is used to dry up smokers. Usually induction is done starting with IV fentanyl, 0.5 to 1 microgram per kg, ideal body weight, giving 3 minutes before to blunt sympathetic response. Then lidocaine, 20 to 30, then propofol, 1 to 1.5 milligram to loss of verbal command. And then when the patient is sleeping, then we can give neuromuscular blockers, 0.6 to 1 milligram. This is intermediate acting for difficult, predicted difficult airway or respiration risk. We can go for Succa. Nitrous oxide is nitrous oxide, although in some centers our nitrous oxide pipeline is even abolished, but for enhanced recovery, nitrous oxide is advocated because it helps facilitate both uptake and removal of inhalation agent. Nitrous oxide is recommended, although there is some increased risk PONV, but can be mitigated with prior intermittent dose. Fentanyl intermittent bolus doses of 25 to 50 micrograms given when heart rate or blood pressure rises, but limiting to 1 microgram per kg per hour. Once this is exceeded, the beta blockers or vasodilators has to be given to treat hypertension or tachycardia. So SEBO, we are using SEBO mostly 0.8 to 1 MAC with nitrous oxide and 50% oxygen. With monitoring of the BIS and end-tidal agent concentration, we are also monitoring. Avoid deep level of anesthesia. But TIVA is good for high-risk PONV patient, although meta-analysis reports no overall difference if one antibiotic is added before. TIVA regime is for propofol is 75 to 100 mics per kg per minute with EEG monitoring. Remifentanil nowadays we are using as an opioid component for TIVA.